Hello, everyone. Welcome to today's virtual panel. My name is Rebecca Vallis. I am the Chief Executive Officer of the National Academy of Social Insurance, and we're thrilled to welcome you to today's conversation. I'm going to start by giving a brief visual description. I am a white woman with today quite unruly brown curly hair, and I'm wearing a black blazer, and I'm sitting against a backdrop of a whole bunch of books because I'm sitting in the National Academy of Social Insurance's library full of books about social insurance. And I'm thrilled to welcome you to today's conversation about why social insurance matters to the disability community. July marks 34 years since the signing of the Americans with Disabilities Act. And in recent years, it's come to be marked by many in the US disability community as Disability Pride Month, as we'll hear about in just a moment. And in fact, today, July 26th, marks the day of the law's signing in 1990. Much has changed for people with disabilities in this country in the decades since. We've made significant progress as a society when it comes to disability rights, inclusion, independent living, economic security, and more, and critical social insurance and related programs such as Social Security disability insurance, Supplemental Security Income, Medicaid, Medicare, and the Affordable Care Act, just to name a few, have all been a big part of that story. But more than 3 decades on, while there is much to celebrate, and we will do a lot of celebrating in this conversation today, we must also remember that core goals of the ADA remain unfulfilled, and outdated public policies like asset limits, as well as persistent gaps in our social insurance fabric, such as long-term care, are part of that story too. So we at the National Academy of Social Insurance are excited to mark today's ADA anniversary by digging into why social insurance is so important to the disability community, as well as the road ahead within the social insurance ecosystem to realize the as yet not fully fulfilled promise of the ADA. And it's my honor and pleasure to get to moderate an incredible panel today. I'll go ahead and welcome them onto the virtual stage with me now. Maria Town, President and CEO of the American Association of People with Disabilities, better known as AAPD. Nev Jones, an assistant professor at the School of Social Work at the University of Pittsburgh. Keith Jones, president and CEO of Soul Touch and Enterprises, and Taylor Cardy, who is the National Academy of Social Insurance Eileen Sweeney Disability Policy Intern this summer, and an MPH candidate at UCLA. It's wonderful to have all of you with us today. Thank you so much for joining us for this conversation. Maria, I'm going to go ahead and start off with you. I mentioned that a lot of progress has been made in the decades since the ADA was signed. And of course, the ADA is just part of that story. There's also lots and lots of other important laws and Supreme Court cases and regulations and other things that I think will probably come up today in that context. But just starting with some of that progress that we've made, I'd love to give you the chance to lead off by talking a little bit about how social insurance and related programs like Social Security disability insurance, SSI, Medicaid, Medicare, the ACA are the ones I mentioned up top, how those fit into that broader story of progress.
Yeah. Well, thank you so much, Rebecca, and thank you for having me here. And I'll just describe myself for access purposes. I'm a white woman with long brown hair. I'm wearing a bright pink dress and lipstick that matches, as well as pearls, and my pronouns are she, her, and hers. So happy anniversary, ADA, and it's a big moment that the National Academies of Social Insurance is having this event, because as you kind of hinted at, social insurance and other programs like it play a core role in making the goals and ideals of the ADA a reality. One of the biggest critiques of the Americans with Disabilities Act is that it is an unfunded mandate. And that is really because the Americans with Disabilities Act is a civil rights law. It was not a part of an appropriations process, right? And so programs like SSI, SSDI, Medicaid, Medicare, I will go ahead and add SNAP and TANF, WIC, are programs that actually make it possible for people with disabilities to stay in our communities and access the services and supports that we actually need. The Americans with Disabilities Act includes an integration mandate, which is how we got to the Olmstead decision in 1999. But even with, a Supreme Court decision, disabled people can't stay in our community if we can't afford to live, right? And SSI, Medicaid, Medicare, all of these programs actually provide the funding that enables it. Now, do these programs need significant reform and need to be improved to actually make their goals work along with the ADA? Absolutely, yes. But when we talk about disability civil rights, we cannot only have a conversation about the Americans with Disabilities Act or the Rehabilitation Act. We actually have to include SSI, SSDI, Medicaid, Medicare, and the like, and also the ACA, which is a whole different conversation. I think I had a conversation yesterday with Hy Feldblum, who was one of the people that worked on the ADA in a variety of different capacities. And Hy's actually had a very interesting career in that she then went on to work in places like the EEOC to make the ADA real. And one of the things that she shared was, the ADA was really about civil rights and not charity. And I think when we look at social insurance programs and the way that those programs understood disability, it was through this kind of charity frame. That's how those programs were originally intended. But with the passage of the ADA and with it, becoming law, we have this bill that is based on the idea that disabled people are a part of the diversity of our nation, and that as a nation, we actually need to be able to celebrate and capitalize on the talents of every person. So disabled people can work and want to work, for example. We can have families and go to the grocery store and participate in business and participate in community events. And so I do think that the ADA was a part of a shift that is not entirely complete, but of seeing programs like SSI and SSDI shift from this charity kind of background into a individual empowerment, economic self-sufficiency kind of frame. And we're far from those goals, but yeah.
And a lot in there that I think we're going to get a chance to unpack throughout today. I want to say also just congratulations to the American Association of People with Disabilities on a wonderful event last night. It was fun to be with you and
Thank
a
you.
lot of folks in community in person getting to celebrate. Maria, you're a member of what sometimes is called the ADA generation. Our friend Rebecca Coakley, I think, actually coined that term at some point. But Keith, you've been around a little bit longer than some of us. And so you've seen a lot of this from maybe a different generational perspective. I'd love to give you the chance to answer the same question about how you see social insurance and other related programs, some of which Maria's been talking about, fitting into that larger story of progress as we start with the celebratory note.
Well, thank you. And Maria, thank you for the setup. My name is Keith Jones. I'm an African American male wearing glasses with a green shirt sitting in my COVID bunker from years ago. The irony of the break between the 88 generation and those of us that saw it coming is that I'm speaking out of school. I'm a little bit older than SSI by a couple minutes, but uh, what what it has done and what it did for kids coming out of the 60s and 70s is that there was no way to make money. There was no support for families. There was no income coming in to support your child with a disability, but there also was no vision for your child to even go on to be included in society. So if you, just in my lifetime, 5 years before the ugly laws were eradicated, I was there. 10 years after signing the Voc Rehab Act, was finally allowed to go to quote unquote regular school. So the economic engine of SSI was, well, we'll give you something so you don't die quickly, but we won't give you enough to stay alive. So the story with SSI has been not so much as the economic driver of moving on or upward mobility or community engagement. It really was subsistence that, along with Medicaid, Medicare, all these other programs that came along with, 504, vocational rehabilitation, those issues were also in the context of America having a reflexive reaction to the civil rights movement, the immigration movement, the land back, also the time of coming out of war with Vietnam. So there was these larger social contexts, and social security or any of these things were not seen as ways to stabilize the community in order to move forward. It was the charity model because there was no forethought of these kids will graduate to go on to be presidents of AAPD or researchers or PhD students. It was always seen as, well, we have social workshops and here's a little bit of money. So I think as we go back and going forward as well, even on this day, celebrating 34 years, it's okay, we're still here, but we still wait. And so how do you make the American dream real for 60 million Americans if the social construct behind what underpins it is charity? Or we look at you not as a fully functioning human being, but we don't want to be seen as putting you in the oven like a Pop-Tart. So it's those kind of things that put people in context with, yes, you can go to school until you're 22, but we'll transition you and you'll get a check. And so that kind of psychology is permeated. But I think as we've gone forward, the post-ADA generation sees like, I want a house, I want a relationship, I want to be able to travel, I want to be able to do things in my community. But beyond that, how do we do that with no money? How do you do that if you are asked to pay rent, but your SSI is $400 shorter than what they're charging you for rent? How do you subsist on, income-based housing when people in the United States believe it is a charity model, and depending on what your socioeconomic demographic is, it could be gender, ethnicity, or class. You won't get those kind of hands up or hands out. How do you get a business loan if you can't meet the asset or having things like that? How do you buy a house? How do you get a car? How do you get your car modified? If Voc Rehab says, buy the car and we'll fix it, but you can't sell it after that because the structural modification. So there are a lot of things that we saw in my lifetime that were great, but we have a long way to go.
Yep, and that's exactly why we're going to have this conversation today. Nev and Taylor, to give you a chance to weigh in on this kind of first chunk of our conversation as well. And I'll add another layer to it, which is that each of you brings significant policy and research expertise. But my understanding is that everyone on this panel also has some lived experience with aspects of this ecosystem, which I think further enriches today's conversation. A lot of times social insurance gets framed up as being about retirement. I participated in a conversation earlier this week talking about Social Security, and the retirement piece is the piece that people are most familiar with. But obviously, and we're starting to get into this, and Keith and Maria have started to tee this up, social insurance also includes really important elements that are for people with disabilities that are intended as disability protection, even though, as Keith and Maria are teeing up, we have a lot to talk about in terms of improvements that are needed. But just kind of further laying the table on what social insurance means to people with disabilities today. Taylor, I don't know if you want to maybe weigh in next with why social insurance is important to people with disabilities and what aspects of this ecosystem have meant to you.
Absolutely. Hi, everyone. I'm Taylor. I'm a white woman with auburn hair, and actually wearing a National Academy of Social Insurance t-shirt. And I'm currently at the academy with a white background behind me. So in my opinion, having cerebral palsy myself, I grew up in California, and I was part of a program actually called California Children's Services, which provides children with chronic conditions the healthcare services they need up until they're 21. And while they were on SSI, some of them, the biggest aspect was the Medicaid portion in California Medi-Cal, but around 77% of CCS children are Medicaid eligible, and they are actually right now in a Medicaid managed care program. So just in terms of social insurance, without Medicaid, they can't access the surgeries they need to be able to walk, to just to make progress in terms of their not only their mobility, but also making progress in terms of their ADLs, which is not only a short-term goal, but also in terms of the longer term where they're trying to be more independent as adults and having increased independence, and just in terms of job employment opportunities as well. And as you get older and potentially volunteering, I volunteered at my local rehabilitation center. If you acquire disability, not as a child, but later as an adult, then you have to navigate the system, and you're more reliant on Social Security programs and other social insurance programs to make sure you have a safety net that's very much needed, because in the traditional system, a lot of services that you would think were covered are traditionally not. Only Medicaid covers them. And so it's such a crucial aspect to just being able to not only live your lives, but just integrate into the community and have just do what you want to do.
Thank you so much for that, Taylor. And I'm waving my hands because the lights will go off in this room every so often. We like sustainability, but then we wave our hands. So Nev, I want to go to you next. A big part of the focus of your research and a big part of what you often educate folks on in spaces like this is what social insurance means to people with mental health and psychiatric disabilities of varying types. Would love for you to bring in that perspective as well.
Yeah, absolutely. So hi, everyone. Just brief description. I'm actually in a hotel in Harlem. So there is an exhaust grate behind me because I had to check out of my hotel room. Short white woman with wire-rimmed glasses and shoulder length brown hair. And today I am wearing a yellow sweater over a red t-shirt. So it's great to see folks here. In terms of the mental health piece, I think one of the things is that the psychiatric disabilities community is so embattled on multiple fronts. And I think one of the issues that tends to suck up a lot of energy is involuntary treatment as this kind of civil rights issue, expansions of that through programs like assisted outpatient treatment and care court in California. And these are like these sort of acute crisis issues. Police response to mental health crises is another like really, really big area. And because so much attention is diverted just to triaging these kinds of issues, poverty tends to get less attention. And yet, I think building on what Keith was saying earlier, income is the absolute foundation. It's the rock on which, everything else is built. So if you are living in entrenched kind of institutionalized poverty, your ability to really flourish in society is incredibly, incredibly minimal. And, we see ripple effects. So living in poverty means that you're going to end up de facto segregated, right? Segregated in poor, higher crime neighborhoods that are often food deserts that lack access to green space. You're not going to have the ability and the resources to work towards a higher wage career ladder job because you're trapped in pure survival. So even if you're on SSI or SSDI trying to work just a bit, it's such a survival work mode that people end up in, that actually like kind of full community participation in the sense of really access to the full range of careers, positions, jobs, living wage pay are not there. So I think we tend to get, we as in sort of the mental health psychiatric disabilities community often tends to get caught up, right, in certain issues that seem immediate and urgent, and this has sort of left this foundational work often kind of underaddressed and neglected in a lot of ways. I will just add that psychiatric disabilities, especially for young to middle-aged adults, right, this is one of the absolutely largest categories of among SSI recipients, if you counted autism in that, which all these, kind of artificial boundaries that we have to deal with, it's absolutely huge. So this should be an absolutely huge, pressing, central issue for reform, which I know we're going to kind of talk about more for folks on the psychiatric disability side as well as across the spectrum.
I appreciate that so much, Nev. And just to say, you and I have had these conversations in, one-on-one spaces, but I really appreciate the leadership you're bringing to try to bring more folks from the psychiatric and mental health disability community into these conversations, given that there's also a siloing that happens even within the policy discourse. It's one to break down. So Maria, I want to give you a chance to weigh in on this piece too, just from the standpoint of SSI in particular. SSI's 50th anniversary has been playing out this year. It's the 50th anniversary of SSI checks actually starting to go out, which happened, the first checks started to happen in January of 1974, which, as Keith has pointed out, was not a history lesson for him. He watched it happen. Some of us had to learn about this because we were born later. But Maria, you've spoken about, including in events you and I have done together, about what SSI has actually meant in your life, and some of the foundation and the, I'm going to use Nev's word there, that it provided for you. I don't know if you want to weigh in with any of that as we mark that anniversary this year as well.
Yeah, I would be happy to. Like Taylor and like Keith, Becca, you actually have like amazing CP power on this event. Just letting you know. So I have cerebral palsy myself, and was on SSI from early childhood through college. And for me, when I think about SSI, I think about two things. I think about what it meant for my family. My mom was a single mom who raised 3 disabled kids, and I remember my mom putting herself through nursing school so that she could get a career that would earn enough to make sure we could keep a roof over our heads. But in that gap, SSI helped pay for my family's groceries. Like it really provided very necessary support that meant we could continue moving towards a better future for me. I think one of the things that is really important to my story is that I don't know if this is going to make any sense, but I was one of those kids who grew up poor that didn't realize it because my mom worked hard so that I didn't realize it, which also meant that unlike many young disabled people, I was always encouraged to get a job and find employment. I was never, I didn't have to deal with like the fear of losing my benefits as a guiding force in my life as I began to navigate like the school to work transition. That is not true for most young people with disabilities who receive SSI. And like Keith was saying, getting SSI and knowing about how the substantial gainful activity limit works can really kind of stop you before you've even started on your journey. One of the things that I haven't shared, Rebecca, is that, my brother has very significant psychiatric disabilities and is a current recipient of DI, I believe. And that too, once again, has been a huge help to my family. And so when I think about my own journey, one of the reasons that it motivates me is because I know that I should not be the exception, right? Like my experience should be more of the rule. And people, young people as they're starting out their career journeys, or people who have become disabled who are interested in returning to work, should not have to confront their dreams with worry because of the way our benefits are structured. The benefits should do what they are there to do, which is to actually support people and help people thrive. So
Yep.
yeah.
Yep. Thank you for sharing that, and both from your perspective and also sharing about your brother. And we do have some really big CP power on this call. I'm very into it. So one last question in this chunk of the discussion, and then we're going to segue just a little bit and switch gears. And that's that, Taylor, you brought up Medicaid, and I want to go into that health side just a little bit in particular, Medicaid and the Affordable Care Act. And we're not going to get into any kind of a partisan discussion here. We're not going to get into an electoral discussion here. We are in a fully 501c3 space, but we do have an election coming up, and there is a lot of discussion in that election about the ACA and about Medicaid and about what might be at stake depending on the outcome of that election. And so I'm curious if each of you might want to speak just a little bit about what's at risk and what's at stake, particularly for people with disabilities, as we hear that Affordable Care Act and Medicaid debate start to come back up. And as I ask that question, I'm flashing back to 2017 when we had very serious threats to the Affordable Care Act and Medicaid, and remembering that it was the disability community that in many ways saved the ACA and Medicaid. And so this is not necessarily a theoretical question to each of you. And Maria, I don't know if you want to start with that, and others may want to weigh in.
Medicaid unwinding, where do I start? There are so many people who live, well below the income threshold for Medicaid, who have recently lost their healthcare coverage because of the Medicaid unwinding process. And it's been for different reasons in different states. Some states have arbitrarily just removed people from their roles. Others have done kind of notification and outreach via mail only, which people haven't gotten because they have moved. The Medicaid enrollment process is often fairly complicated and hard to understand for folks, so they haven't been able to engage in the process to re-enroll as unwinding has taken place. And so at a moment where we are actually seeing a greater increase in the presence of disability, and the CDC released data about 10 days ago that there are now 70 million disabled adults in the United States. And at a moment where we are dealing with increased inflation, where it's harder for Americans to meet their basic needs, we are seeing tons and tons of people lose healthcare coverage that is meant for low-income folks, and it is cruel. And that will remain true regardless of what happens in the election. So we need, the reason that a lot of unwinding is happening is because of the end of policies that were established during the COVID public health emergency. But in my opinion, what states should be doing is actually figuring out how to maintain coverage. And I'll tell a personal story here too. I'm originally from South Louisiana, and I received I received Medicaid waiver services as a child, and these services covered physical therapy, they covered occupational therapy, they also covered in-home supports for my family and respite for my mom. And when I was about 10 years old, the government in Louisiana changed. They reformed the state Medicaid program, and I lost my Medicaid waiver and Medicaid services because I was, quote, too smart. My CP is still here. I still struggle to perform many activities of daily living, like Taylor mentioned. We fought this determination in court. It's one of my first advocacy memories, and we lost. And so I went without PT and OT and in-home services and supports for years. And this is what's happening to people across the country, even though their disability status and their income status aren't changing.
Thank you for sharing that story. Taylor or Nev or Keith, I don't know if any of you want to weigh in on just obviously Medicaid unwinding is in progress, right? That's not theoretical, that's happening. But also the stakes when it comes to Medicaid and the ACA also potentially being up for debate. Any of you want to weigh in on that as well?
I'll just jump in real quick so I can check. Having worked on Medicare for All, as health for all, that led into what turned into Care, which turned into the ACA. Everything that we fought for was universal health care, specifically holistic health care, meaning mental health, vision, dental, physical therapy, and home services. And what people have forgotten is a lot of the pitfalls and traps because policies were shaped via compromise, not via solution. People had ideas, but how do you move these policies through a political system that will use these programs as a political curmudgeon? People forget that the SSI Treasury Fund, or the fund was being raided. People were complaining about it being used for war. I just, like the story you heard yesterday, found out that I no longer had a disability according to Medicaid and Medicare. I was like, I didn't know cerebral palsy could turn on. I mean, I'm sexy, thank you, but I didn't know the CP would just evaporate.
It's a miracle, Keith. You've been cured.
Wait till I start breakdancing in 2028. It's those kind of things where I think the frustration for the community is not that we don't know what effective policy is. That's never been the issue in the United States. It's the policies, particularly for our community, particularly around healthcare, has never been driven about giving people a quality outcome. If you have schizophrenia, mental health challenges, or mild depression that requires some sort of support, because you needed an agency of tie, and because of the way we've structured this, we've always had to pick which disability do we need to have help today. So you can't, if you're autistic with a mental health challenge and some mobility impairment, then you are like, I just need help. But walking into the office, and because of the way states, governments, and even over the last 60 years of healthcare policy has shaped this has never been about giving us an effective outcome. This has always been about doing just enough so we've not done enough. And so the challenges have been, how do we not have people who are sitting in a room say, we know cerebral palsy is a lifelong issue, but because we sent you a letter in the mail that you never got, I just got unenrolled 3 days ago. So this is happening today. So yesterday they were like, oh, we're going to put you back on because you do have cerebral palsy. So these are the kind of things that are not because the community has said we don't want it, but there is an intransigency within the political system and policy making that never has factually been designed to eliminate the barriers for our community. So you should not have to say, my mental health is more important than my physical health. It's your health, full stop. And so the challenge has been, how do we get our community to get out of the silos of saying, no, we're only going to support the autistic community. No, we're only going to support the DD community. No, we're only going to support spinal cord injury. Like, those are real hardcore issues. And the challenge is getting people to, one, get out of their own way, but two, have effective policy written not from a point of compromise, but a point of solution. And so that's the challenge that we've been facing for the last 100,000 years.
And of course, Keith, some of what you're talking about also isn't even just about what the policy is, right? I mean, technically you might remain eligible for a program, but that doesn't mean that you're going to maintain the eligibility, right? Because a lot of the systems and the bureaucracy don't always get implemented in ways that are really ones that center the person. Taylor or Nev, was there more you wanted to add on Medicaid and ACA before we move on?
What I would add quickly, and this is in part because the National Academies of Science, Engineering, and Medicine put on a really powerful workshop a couple of weeks ago on the behavioral health workforce, but one could expand this to the Medicaid workforce, period. And that is that Medicaid policies and Medicaid reform profoundly influence whether there is a workforce, the robustness of the workforce, and a further layer of those impacts on the disability community is that actually a very large number of people with disabilities are working at the sort of the bottom of the kind of workforce ladder within healthcare, whether that's as in-home aides, peer specialists, community health workers, et cetera. And their pay, and again, ultimately this becomes an issue of poverty, is dictated by Medicaid and Medicare financing, case rates, et cetera. So I think it's another area where very hard-won progress in some ways is really, really at stake. So the services then that people with disabilities are even able to access are also dependent on the workforce that's there. And we see flight from the public sector to only working under private insurance, and in certain kind of professions, among psychiatrists, for example, huge flight even from private insurance into just pure out-of-pocket pay. So we have to address those issues too, and they're a little bit more distant at first glance, and they have these profound impacts on what kind of services are actually going to look like for folks. So I mean, on bottom line, I think, as we're all saying, so much is at stake in this election, and so much progress that we're just sort of starting to make could be rolled back.
Yeah, thank you so much. That's such an important point, Nev. And Medicaid also being incredibly important for people with disabilities to be able to work, right? For a variety of reasons, right? So very connected to work. So I want to switch gears a little bit and talk about, what does the road ahead look like? Because you guys have all already started to identify a lot of the challenges, and I feel like it would be quite unsatisfying if we just identified a bunch of challenges and we didn't actually point to some of the solutions and some of the proposals that get talked about, some of which are very seriously getting talked about in a variety of contexts. And so as I do that switching of gears, I actually want to invoke some words from Senator Harkin, who was one of the architects of the ADA, and who a former senator from Iowa, and who also joined the Academy for the 50th anniversary of the SSI program for an event that we did back in June. And so for anyone who's not aware, I think most people listening probably are, but quote, economic self-sufficiency was one of the core goals of the ADA when it was signed in 1990 and as it was crafted. And of course, we're still a ways off from that for a variety of reasons you you all have been talking about, right? One stat that always feels right to bring in that context is that people with disabilities in the US still face poverty rates about twice as high as people without disabilities, right? And so back to Senator Harkin, he spoke passionately at the SSI 50th anniversary event about the fact that there are actually very specific rules within SSI that are incredibly out of date, such as asset limits that haven't been updated even for inflation since 1984. Which, as I often will share, was the year I was born. And Keith, you can laugh at that. And other rules as well, but that those rules being so outdated, Senator Harkin noted, actually directly stand in the way of realizing the goals of the ADA. And so we've got one part of government sort of speaking out of one side of the mouth saying, yay, economic self-sufficiency and independent living and equal participation and all the things. But then we've got this other part of government saying, and also don't save and don't make more than this much and so forth. And so we're marking the 34th anniversary of the ADA today and all month in July, but we're also, as I mentioned before, marking the 50th anniversary of SSI. So thinking about Senator Harkin's observation, I'd love to give you all the chance to sort of offer a message to policymakers that might be reckoning with some of these conflicts right now. What should folks know about the ways that SSI in particular needs to be brought up to date so that it doesn't directly impede the fulfillment of the ADA? And Nev, I want to start with you on that one.
Yeah, so, and because I was at Senator Harkin's really incredible talk, I think what he was emphasizing is this bifurcation, this forced choice between if you're working, you're not disabled enough. If you're really disabled, you're not really able to work. And then, you know, kind of policies, whether built into SSI, whether that is asset limits, various kinds of work penalties, really decision making as it's shaped by the risk of overpayment, the ramifications of overpayment. So an assortment of things that really push people into, even if I want to work, even if I could, the risks are so huge, the loss is so great of systems that I'm dependent on that are linked directly or indirectly. So whether that's housing, subsidized housing, Section 8 voucher prioritization or access, Medicaid, etc., the loss of that is huge. And then you are trapped, right? You're trapped well below the poverty line. And then on the flip side, right, the ADA has, and this is where the ADA and SSI are really interlinked. The ADA has really, really failed to bring about equal opportunity when it comes to employment and educational settings. And so the discrimination that people face, the lowered expectations of what they're capable of, the lack of kind of creativity around robust and substantive accommodations. So people are really being, you know, kind of forced backed into a corner. From a policy perspective specific to SSI, I think there's this deeper conceptual thinking that Senator Harkin is maybe was calling for around why are we forcing people to, in order to access benefits, they should be able to benefit from not work, because in a sense we are forcing them to either work very little or not work at all in order to access those benefits, as you were saying, at odds with the ADA, at odds with the goals of financial empowerment and inclusion. On the other hand, there's all these restrictive policies built into SSI that just make it very, very difficult for people to navigate. There is a lack of clarity that I think is widespread as to how to navigate the rules. There is people who have been so traumatized by overpayment experiences that the risk is so great that working at all, even if they think, well, it's going to be within the limits, but who knows what will happen. So I think there's clarity, there's improving communication, but there's also, you know, kind of changing these rules and the sort of the punitive nature of them, and just the asset limit, because there's been so much work. Hopefully other people will pick up on this and talk more, but it is an absurdity, right, to put people in the situation in which they cannot save, knowing that they often have large big ticket expenditures related to disability that they cannot make without, without kind of trying to save for. The marriage penalty is another one that kind of places people in and entrenches them in social and relational precarity on top of everything else. So there's really a lot of work to be done there. Some of that is lower hanging fruit. Some of it is going to take a lot of change, right? And a lot of work.
I appreciate all of that, Nev. Keith, I don't know if you want to pick up there. You and I have had more than a few conversations about the absurdity of the $2,000 asset limit, and a line that often echoes in my head as I think about these issues is you often say that people with disabilities have to work until you die because of policies like this. Pick up where Nev left off.
So thank you. And yes, so the NCD last year had their annual meeting where they had presented the report on suggestions to lawmakers about how to restructure, reframe, and move these barriers. But what people have forgotten is that those things are intentional. Mm-hmm. Policy is people writing these things into place and then rationalizing why this makes sense, and then telling you that putting you in abject poverty is for your best outcome. Mm-hmm. That is not people's desire to be poor. So the way policymakers must move, and and I'm going to take a little liberty here. One of the things that we have to understand is that anybody in a position to write policy who says, I'm unaware of restrictive negative outcomes by saying you can only have $2,000 in the bank, and say, well, this is because if we give you more, then you won't be poor. That's the point. But the question then becomes, in these policy gaps or these policy barriers, who benefits from those barriers consistently existing? If I can't pay rent, but I can be put into a group home, it doesn't benefit me. It benefits the person who has the group home contract. If you can pay a agency $90,000 per bed, but you'll give me $600 a month, then where's that gap? That's somebody wrote that. Then people will say, well, they have a powerful lobby arm that pushes these things. So much like the ACA, much like Medicaid and restrictions, much like these things, these are intentional. So how do we get rid of that? It's not about voting particular policy lawmakers into office. It's about having a vision for a country that is not being punitive based upon your human condition. And that requires individuals to not take their own biases into the policy writing room. There's nothing that says what we're going to look at the human condition and say what happens in your brain has nothing else to do with your heart condition, your mobility, which means that you are looking at me not as a human, but as a segment. And that is a conscious choice. So how do we shift that? We shift it by saying, okay, it makes sense that one of the barriers to economic growth of the country is giving the community disposable income. How do you give the community disposable income? If you're not going to give them a living wage or an ability to earn a living wage, then you understand on the back end of that there are going to be poverty outcomes. You're not talking about people who are in places in rural areas where paratransit is little to non-existent. You're not talking about the digital gap that exists. You're not talking about the limited outreach to going on to higher education. A lot of us on this call are exceptions to a rule, which we shouldn't be. But so how do we do that? That is working with the NEA, National Teachers Association, and saying all students should be taught. That's working with CMS and saying your arbitrary laws about what constitutes a disability is looked at it from a medical model versus a holistic model. We have to understand that a lot of the frameworks in this country in terms of policy are not framed upon cultural existences of the vast, it is a very dominant Eurocentric view of the medicine and the medical complex. So it's not complicated because we can go to war in 24 hours and fund it in the blink of an eye.
Yeah.
So to tell people that changing these policies is going to take yeoman's effort is actually not true. It requires people in place to say, we know where the barriers are. We've had 50 years of data. We understand that if we remove these restrictions, this will then ignite people's ability to be entrepreneurs, sustain themselves. If you're talking about, oh, we love the nuclear family, but then you put restrictions on who can get married because they have a disability, then you're not upholding that. These are not, the policies are coming from places where people are making cultural decisions based upon the way they see the world. Yeah. And so that has led us to the barriers, which is why if you say you have a mental health challenge, 20 years ago, we did the disability pyramid. If you're a white spinal cord injured male, you're at the top of that pyramid. If you have any cognitive or mental health challenge, you are essentially at the bottom, and all things in between. That's not because the community asked for that. That's because those in place that said these are the decisions we're going to make. So hopefully, going forward, we will do what most people do, is write the legislation and walk it to them and say, pass this. Write the regulation and say, this is how it's going to be done. Because we had history, 50 years of that happening across issues around gun control, environmental, transportation, and finance. So if we can get something like that for our community, I think we'll be good to go.
Well, and I mean, a big part of what you're basically articulating, Keith, right, is the disability community mantra, right? Nothing about us without us, right? Because very different policies get written when it's policymaking and politics of otherization versus people saying, here's what we actually want to craft for ourselves. Right. Taylor, I want to give you a chance on this piece as well before we move on from SSI, although Keith has taken us, as he always does, into much broader territory. And so just kind of coming back into SSI briefly before we move on, you and I have had a number of conversations about this, so I would love to give you a chance to talk a little bit about how some of these outdated rules in SSI that others have been mentioning stand in the way of work and savings for disabled people. And in particular, something that has been innovated in recent years is something called an ABLE account, which is sort of a strategy for being able to safely save some money without jeopardizing benefits. This is something you have a lot of knowledge on. Are ABLE accounts the right solution? What are their strengths? What are their shortcomings? So any of those pieces that you want to take to finish us out on SSI. Oh, and I think you're on mute, Taylor.
Sorry. In terms of SSI specifically, I really think there needs to be change regarding certain policies like the in-kind support and maintenance first, because while there is an amount, like Keith has said, expecting a person and their family to live on that amount is not realistic in just today. And if you are getting support from a family or loved ones, that should definitely not be penalized, because that just puts you that much further back from making progress towards your goals and becoming independent and achieving financial stability, as well as the marriage penalties, because if you're receiving support from a spouse, then that will arguably put you, not arguably, but that for sure will put you at a disadvantage, because that spouse could also be helping to support you, not being able to earn another kind of income. Just it closes the door to so many possibilities. For ABLE accounts, there are so many benefits right now, given the current reality. we can't automatically change the asset limits or the income limits. And so in terms of the asset limits, they offer a way to be able to save and invest for the future and develop a sense of financial stability without being able to lose your Medicaid benefits or your SSI benefits up to the first 100,000 for SSI. There's no limit for Medicaid. As much as I love able accounts, there are certain drawbacks. They don't offer as much freedom as a traditional retirement account in that you have to use it for a specific disability related expense. That being said, the list is very, very broad. So maybe you can get creative on the wording, but at this point, it states disability related expense. I also think there needs to be more education on the investment side of it, because as we all know, investing is very important. And especially in terms, if you can start earlier, the better, in achieving more financial independence and freedom. But at the moment, there isn't much, their able accounts are underutilized, and there isn't many resources where you can especially go to adults or especially families who have children who have disabilities and say, look, this is the current reality, but you should be able to invest for your child's future. Here is a tool that will allow you to do that and to offer them a way forward, especially if they need more independence later, more dependence later in life, and the parents want to plan. So just having resources around that. That being said, I will say one benefit of able accounts that I kind of like, that it is in a gray area, but with traditional retirement accounts like IRAs, you contribute to your IRA, but then a lot of people don't have the option to contribute to a 401k. With able accounts, if you are working, then even if you don't have a traditional 401k set up, you still can contribute to it, which is amazing, I think, in a sense, especially if you want to explore some opportunities how you wouldn't traditionally explore otherwise.
Thank you for all of that, Taylor. And you make such an important point that able accounts are incredibly underutilized. I think the data I've seen are that it's somewhere around less than 1% of people who are eligible for them are actually even aware that they exist, let alone using them. And so definitely a lot of efforts being led to increase outreach. But as you noted, also, there's a lot that can be kind of confusing about them. So it is definitely an area where there's a lot of attention that could and should be paid around supporting people and being able to use them while policymakers work to do things like update asset limits, right, which are, of course, the underlying challenge that they seek to solve. So Keith brought up marriage penalties. I think Maria has mentioned it as well. I kind of want to bring it up as its own topic, just because it feels like it's worth digging into a little bit. While I do that, I'll just go ahead and invite our audience to put questions in the Q&A function. If you've got questions for our panel, I'm going to ask a few more, but I would love to have questions to start coming in so that we can get them to our panel as well. So go ahead and pop questions in using the Q&A function. And I think we've got a few that are piling up in there already. So marriage. So if a couple of you have mentioned this, and I would love to just get into it a little bit on its own. Among many different ways, as you've all been articulating, that there have been real cultural shifts and real shifts in expectations around what people with disabilities deserve, are capable of, et cetera, in this country over the decades we've been talking about of history. One of those key shifts has been around marriage. I won't name the person, but I was speaking with a reporter not that long ago for a story about this topic, and the person said, so people with disabilities seem to be getting married now, huh? And I did what Maria just did, and I said, Okay, and I took a moment. I said, "Yes, yes, it is happening. It is happening." And so, when at the same time, we do have programs like SSI, and actually, there's an aspect of Social Security disability insurance that does this as well for certain people, that actually outright penalize marriage. And so, I don't know if any of you want to speak specifically to that and to any of the efforts underway to address that. Um, Looking around to see who's interested in taking that one, Maria. Mhm.
So part of the reason I'm taking this, because I actually have an essay on this in a recent book called Disability Intimacy, where I share that the moment I got engaged, I had to immediately consider what it would look like for me to get divorced. Because I think it's important when discussing marriage penalties or marriage disincentives, we're not just talking about policies that prevent people from getting married. We are talking about policies that also require people to get divorced in order to get the benefits they need to survive. So on a basic level, the asset limit for a married couple is so low that even if two people who are on SSI get married, they risk losing their benefits, even though they are both living in poverty. And we also see very frequently that couples where one person, for example, becomes disabled or develops a more significant disability with increased care needs, for example, they have to impoverish themselves by spending down their assets and getting divorced so that they are able to qualify for SSI and Medicaid in order to receive personal assistance services or direct support services, because Medicaid is really one of the only insurance payers who will, or that will cover direct support services for people with disabilities. And so there are, disabled people across the country who are, who have, beautiful, committed relationships, who cannot get married and or who have to divorce. And in my opinion, I see this as an issue on many fronts. It is an economic self-sufficiency issue because there are tax benefits to being married. There are savings benefits to being married. I also see it as a personal mental health stability benefit to marriage, right? But I think a big one, and this, I really think we need to be pushing this framing more. It is also an issue of religious freedom. And I think it's interesting to frame it that way because religious institutions, for example, are not required to comply with the Americans with Disabilities Act or other civil rights laws because of issues of religious freedom. And yet, for people for whom in their religion, marriage is a sacrament, right? Or something sacred, if they are actively prevented from getting married by this benefit system, it is imposing upon their religious freedom. And so there are all kinds of layers to this that I just think are cruel, to be honest. And in many ways, like creating a path for people to either get or remain married, whether they are, straight or LGBTQIA, is actually a means of helping people get on the path to economic self-sufficiency. And when policymakers talk about, wanting to reduce benefits, it doesn't make sense that they want to keep these marriage disincentives and penalties in place.
Thank you so much for that, Maria, and also for the plug for Alice Wong's book, Disability Intimacy, which is something everyone should check out. Nev, I've heard you speak about this too, and quite passionately. I don't know if you want to add anything. It's often said that we have marriage equality in this country, but not for people with disabilities. What would you want to add to what Maria offered?
I thought Maria's comments were really powerful, and I think get to the heart of the issue in terms of marriage itself. And maybe all I would add is the ripple effects across families. So people with disabilities are among the highest risk groups for losing custody of their children, for child welfare, child protective services involvement, often specifically because of perceived neglect that is in fact just a limitation due to disability. This is compounded by poverty, and this is compounded by inability to marry, because that puts people at risk in many ways, right? How they're perceived within the court system, et cetera, et cetera. So it's not just that we are sort of tearing apart the couples, we are tearing apart families, we are preventing kind of strong family networks from forming in many, many ways. So it is, I think, as Maria said, antithetical to the sort of, in a sense, push for, an emphasis on kind of family values and family integrity and family support. So that's what I would add. And I think there's a lot of work beyond even just SSI around the incredible kind of threats that parents with disabilities are often under.
Yeah, thank you for that, Nev. And Maria, to your point about religious freedom, and the faith perspective of this, that is one of the things that's been kind of most wonderful to see in recent years as more and more education has happened on these issues, and as people with disabilities have done more in the way of public events and marriage ceremonies at the Capitol steps, right, and other kind of attention drawing moments. We've seen more involvement from the faith community than I've ever seen on these issues. Including from folks like the National Association of Evangelicals, jumping in and saying, you know what, getting rid of these marriage penalties is actually really important to our faith and to our values. So I appreciate both of you bringing that in. It's also something we've heard a lot about from conservative lawmakers. I'm thinking about Senator Lankford from Oklahoma, who's one of the lead champions of an effort to update SSI's asset limits, which are themselves a marriage penalty, the way that they are implemented. And he speaks about it from the perspective of how much he loves his wife and how he wants everyone to be able to get married, right? So a lot of entry points from that angle. So I want to switch gears a little bit and bring us into another aspect of the conversation. And we're starting to get a couple of questions in here that we're going to go to from the audience in a moment. But I want to just bring in this one other angle before we do that, which is that one of the most significant positive shifts in recent decades when it comes to disability rights and justice and inclusion is deinstitutionalization. It was not that long ago, and Keith can tell us all of this history, that people with disabilities were effectively warehoused in large and isolating institutions more commonly than actually living in the community. And so that deinstitutionalization movement is something that people may be familiar with, but independent living still remains out of reach for huge numbers of people with disabilities. And this was something that came to light in a significant way at the height of the pandemic, when we were having that Build Back Better conversation, and when waiting lists for home and community-based services finally got historic levels of attention. So I'd love to give you the chance as a panel to talk about the current picture when it comes to long-term care and what's at stake for people with disabilities. And in particular, we're celebrating the ADA's anniversary right now, but we're also marking the anniversary of Olmsted, an important Supreme Court case that Maria mentioned before, which promised independent and community living, but hasn't really been fulfilled as a mandate just yet. So Maria, do you want to pick up there and talk a little bit about this issue? AAPD has been one of the leaders on HCBS.
Yes. So I mentioned this before in my previous answer. There are disabled people are still being warehoused, and they're being kind of warehoused less so than in the past, but or possibly in different ways. And Rebecca, I know you've worked incredibly hard to address the fact that prisons and jails are now the largest mental health institutions in most communities across the United States. That is a reality in part because of poverty, and because we have created so many barriers to people actually being able to chart their own path when it comes to employment and pursuing a career. On home and community-based services, Keith actually spoke to this very beautifully. Our systems have a deeply entrenched institutional bias, because despite the existence of multiple disability civil rights laws, the dominant idea of what it means to be a disabled person is someone who remains at home, someone who stays behind closed doors and is not able to contribute in a productive way to a job or to a community. And I think it's really worth noting that the definition of disability within SSI is an inability to work, right? That is not the definition of disability in the Americans with Disabilities Act, where it is a physical or mental condition that impacts an activity of daily living or being perceived as such. The Americans with Disabilities Act definition of disability is a reflection of the diversity of the human experience, where SSI's definition of disability is literally about this thing that is wrong with you that prevents you from contributing. And to me, this institutional bias exists within our public benefits programs, within our housing programs, and within our public healthcare programs. And it makes it more difficult for people with disabilities to engage in what's called self-directed services. When you utilize self-directed services, that process itself can be so difficult that you basically have to work as a small business owner, managing all of your hiring and firing benefits. And one of the things that we haven't talked about yet is how all of these very kind of arcane systems deprive disabled people of time. And so we often don't have time to pursue our interests or dreams because we are spending hours on the phone with the Social Security office, or we are spending hours trying to find a PCA because the person that we've worked with is sick, right? So there's a huge workforce crisis in our nation right now. That is happening in part because many direct care jobs are not good jobs. Direct support workers earn on average $12 an hour. Many of these jobs do not come with any kind of benefits or job security. And part of the reason that these wages are so low is we haven't actually seen an investment in like Medicaid to actually increase benefits. And so there's a consistent tension when entities try to raise wages and disabled people wind up losing hours of service. Our two communities, both the disability community and the sort of care work community, and I want to name that those communities have an overlap. They're not two siloed groups because care workers are disabled themselves, disabled people are care workers, are often put in tension with one another because policymakers give us a false choice. And this is what happens with social insurance all of the time. So I could keep going, but I will stop and let other people comment on this. I've seen a lot of nodding of heads from Keith and Nev.
Yeah, and you're speaking about the care crisis, right, as it's often called in this country, which is both about people who need those types of direct care services. It's also a workforce crisis, as you named. There is overlap across those populations. And one of the conversations that gets had is around investing, fully investing, right, in Medicaid, HCBS, so that we could bring down those waiting lists and so that people would actually be able to receive the services that they're eligible for. But there's also a longer term kind of North Star conversation that many in the social insurance space try to have around should long-term care in some form or fashion, whatever you call it, actually be part of our social insurance system in a more expansive way. I'm curious if anyone wants to weigh in on that or any of the other themes that Maria brought in before we go to audience Q&A.
I'll just jump real quick. In 2004, 2003, 2002, we worked with SEIU to get the direct support workers unionized so that they could fight for 15, so they can get workman's comp, so they can vacation time, paid sick time. Because up until 2002, 2003, you would get a bulk payment, and if your PCA got hurt or sick or whatever, they just didn't get paid. And so again, a lot of these things are intentional because it's written into the policy, it's written into the law. And we have to understand that 50 years ago, the disability, we were handicapped, we were crippled. We were feeble-minded. We were retarded. We were simple. We were mute. That was the lexicon. And so if we step back, and should long-term care supports be part of social insurance? Absolutely. Because again, to bifurcate the human existence solely around a particular instance of a human characteristic shows a lack of vision, shows a lack of, or not even a lack, a chosen myopic view of the human existence. So if you understand that one medical crisis can send you into poverty, and we've known this for years, then the question then becomes, for those people who are operating in this space, what is your role here? Why are you here? If you understand that the underpinning of the social network literally is only 75 years old, like these things are relatively new. And so there are people in Congress who are still there, who wrote these laws, and like, what do you mean you want to have money so you don't starve to death? Well, coming out of a pandemic, you understand the term pandemic means mass disabling event. Now so when you talk about, why are people talking about the fight about long COVID, or any kind of environmental impact? If you talk about it in a socioeconomic and racial or ethnic demographic, if you are in places that have been environmental disasters, there's something called environmental racism. These things are real. Those things don't happen because people ask you to build toxic dumps next to our homes. Those are because policies haven't been in place and enacted. And some of those things are reflected in the way lawmakers have perceived large parts of our community. If you talk about disability, know that everybody, I'm from the era where you had Jerry's Kids telethons. I did Easter Sales telethons. I've done United Way telethons, United Cerebral Palsy telethons. If you help this poor crippled kid, he'll be great. That's not looking at my humanity. That's sort of placating some notion that my version of humanity is not real. And that translates into public policy, which means a healthcare crisis, you understand that people in nursing homes need quality care. So why are you charging $96,000 a bed and taking 80% of their income or SSI while paying the people who make sure that they can eat $7 an hour? Those are chosen acts, and they're written into policy for people to take advantage of. That's not something that the community is asked for. So I think, so in the long term, or the North Star is, do we want a country where people can age graceful? Do you want a country where you can literally be the America that we sell on TV? Or do you want to keep playing, oh, of course we love it, give 15 cents an hour? If I hear In the Arms of an Angel one more time, I might go crazy. So
yeah, and I mean, what you're beautifully giving voice to, right, Keith, is it's moving from that pity charity frame that Maria was talking about before into an us place, right, into understanding people with disabilities as contributors to the economy and to society, right, as opposed to people to be kept somewhere and with just enough. So we're getting a ton of questions around a similar theme.
Rebecca, just quickly, I think it really does bear repeating what Maria said about deinstitutionalization on the psych disability side has meant mass incarceration, criminalization, and institutionalization without walls, i.e. very coercive carceral programs and smaller institutions like IMDs, nursing homes and group homes. And I think we also see really an expansion, a significant expansion of what we could think of as carceral state policies around mental illness. We are embracing whole hog coercion, assisted outpatient treatment, which is, coercive treatment in the community that disrespects, actually outright explicitly, the fundamental need to meet social and structural needs. So people do not get housing, but will get met by police on the streets, held down and injected, quite literally. In fact, I'm here in New York City evaluating AOT implementation across New York State. So there's a lot there that needs to be taken seriously, and simultaneously, home and community-based waivers have not been implemented, are not accessible by and large to folks with psychiatric disabilities. As of 2020, there were only 18 states that used HCBS or other 1915 waivers in a way that made those services accessible to people with psychiatric disabilities. So we see a huge disconnect there in how they're being used, and really disparities. And then the same holds for self-direction. So there's an even smaller number of states that have implemented or continue to implement Medicaid self-direction for people with psychiatric disabilities. So I think we have really a long way to go. And it's always this challenge of, with the silos that we end up with, looking at, well, where maybe more progress has been made in kind of IDD or physical disabilities, there's ways it goes in the other direction, but some of these gains have not been equally felt, and there are mechanisms that exist that are untapped, that states are literally, whether this is due to structural stigma, deeply prejudicial thinking, are not deploying resources at their disposal to help folks with psychiatric disabilities stay out of prisons, jails, and nursing homes.
Thank you for all of that, Nev. And yes, thank you, Maria, for bringing in that intersection, which is not one that is necessarily well understood in a lot of these spaces. And I believe the statistic remains true that people who are behind bars in jails and prisons are 3 to 4 times more likely to have a disability than the general population. And they are disproportionately people with psychiatric disabilities, as Nev mentioned. So we have a number of questions in the Q&A that are all around a similar theme. And so I'm going to kind of combine them into one theme that I'm going to throw out to all of you. And then we're going to close with one kind of lightning round question that comes from King's Floyd that I really like, and I think is the perfect place to end. So the theme that some of these questions are around is around barriers to work and disincentives to work. And with I think an interest and a desire to get a little more specific about what some of the policy options are that policymakers have at their disposal to reduce or remove those barriers and disincentives to work. So I'm maybe looking at you, Nev. Do you want to pick up on that just a little bit and get specific around some of the policy options? We've talked a lot about SSI in particular, and DI as well.
So specific to?
So removing barriers and disincentives to work.
Yeah, I mean, I think that there's sort of 2 buckets to put things into. We need people to have access to living wage jobs, and we need the accommodations and supports in the workplace to facilitate that. And for jobs that are dependent on higher education, we have a serious and deep need for reform around ADA implementation in schools, community colleges, and universities. And if we don't facilitate pathways to a living wage, what we end up with is the only options available to folks who either are on SSI or will end up on SSI is jobs that are so low wage and actually so difficult for those familiar with nickel and dimed, right? What I hear over and over is grueling hours, grueling types of work. And that's what we say, that's what you get, folks with disabilities, disability community. And that has to change, or that reinforces actually SSI becoming the better or only option, because the nature of the work is so stressful and so difficult. And all of us in this room, myself, have a far easier, in a sense at this point in my life, white collar job than I would if I was having to work grueling hours in a factory and janitorial work, etc. So I think that's really important to say. And then specifically when it comes to SSI, right, we really, really need to expand on some of the pilots right, that have shown when rules are relaxed, when people can work with less risk, when they can experiment and sort of feel out whether they can take on a certain number of hours without the risks of sort of loss of SSI and or permanent loss or reduction, loss of Medicaid, that allows people to really gain those experiences and see if they can, you know, what they personally can kind of deal with and handle in terms of, you know, hours that they're working. And then I think, you know, again, that sort of overpayment has become a real source of fear. And enough people have experienced overpayment that even if there's no, in a certain sense, a reasonable reason to think that you're gonna face it, anything that alters, right? Anything that kind of alters the landscape in terms of reporting creates this risk situation. So, and because people are living so on the margin, just one bad experience of overpayment, you know that that can completely push you over the edge. So I think those sort of the two buckets, reform SSI, but reforming SSI alone will not work if we're not building out quality employment options and supports for people and fully implementing the ADA as intended, not as it has become, you know, kind of eroded through conservative judicial rulings and precedent.
And of course, just relating back to some of the conversation today, right? Some of the very specific, you called it low-hanging fruit, Nev, right? Would be updating those asset limits at a minimum, right? Updating those income limits that haven't been updated since 1972, even for inflation, right? That literally reduce someone's benefit when they get even to $85 per month, right? A $1972 figure. So just some specific and granular pieces as well. So I'm going to close us out with a lightning round question suggested by Kings Floyd, hi Kings, and that is, with a magic wand, what are 3 changes you would make to our social insurance infrastructure that would specifically be beneficial to people with disabilities? And Maria, I think I'll go to you first, and then we'll go around the horn.
Well, this is a great lightning round question, but I wanted to say one thing on the last question, so I'm going to do it, which is that the work disincentives in SSI specifically are used as an argument to maintain other employment practices that diminish the labor of disabled people, right? So it is still currently legal to pay people with disabilities sub-minimum wage in the United States. And when you talk to people who are proponents of this policy, one of the first things that they'll say is, I myself, you know, as a disabled person, or my child, or my family member cannot earn more money because they will lose their benefits. And I think this speaks to a real lack of awareness around things like ABLE accounts or PASS plans or the Ticket to Work program, for example. But the fact of the matter is that this discrimination against disabled people through programs like SSI is used to justify further discrimination in other areas of life. And so to answer King's questions, what are 3 changes I would make? And I will repeat what Rebecca has said, is I would increase asset limits, I would increase income limits, and I don't know how, but I would somehow make the process for navigating all of these benefits easier, so that the risk of losing them is not so high that you fear you're never going to be able to get them again if you do find yourself unemployed or in greater need of support.
Yeah.
So yeah.
Thank
I'll
you.
pass it to Keith.
Keith, too.
3 magic things. First and foremost, to get the people who are writing the policies, who intentionally put the barriers in place, get them the hell out of office and get them out of the writing process, because these things are intentional. Secondly, to streamline the process and understand that the bureaucracy only exists to keep itself in power. So that would be to streamline, to the earlier point, make it easier to connect your diagnosis to your eligibility without having to turn yourself into a human pretzel to do it. And number 3, to have a realistic understanding that poverty is imposed and not desired, so that if you're going to set income and asset limits, that the income that people get is set at a livable standard, matched with the COLA index, and that way we can keep it pushing. So those are three things.
Yeah, something that hasn't even come up yet, right? How low the SSI benefits are. They don't even get you beyond 75% of the federal poverty level. Taylor, over to you. 3 things you would do with your magic wand.
Well, one's kind of related like to the SSI, like just going to that back to that point, just in terms of re-examining substantial like substantial gainful activity limits for people who identify as visually impaired or blind versus those who have some sort of other disabilities, because especially for the people that I've worked with mental health challenges, just in terms of their medical expenses and just in terms of other disability related expenses, that extra income could just open up so many possibilities. But it's also, I think it's like 2,950 right now for the limit for those who identify as blind. It's still not enough. So I would kind of want to see an increment, like in an ideal world, just a certain standard that they put that's actually livable. And then there's actually more incentive to work in that there's not this big cliff. There's a more incremental like decrease in your benefits, very similar like to the VA. And so I think that way you could have more room to really explore what you want to do without worrying, okay, this is going to be completely detrimental to me. I'm not going to pursue anything. But also just like increasing the asset limits, because you've seen so much possibility in terms of what California recently did, but even longer ago what Washington State did with just removing the asset limits for people with disabilities in their waiver program, and just making it on a sliding scale so that they could access it, but also pursue the job that they wanted to do.
Thank you so much, Taylor. And Nev, you're going to get the last word. 3 things with your magic wand. And then I know we're a few minutes over, but we'll let everyone go.
I mean, since you said magic wand, Rebecca, it would be universal basic income, and specifically being more pragmatic than universal basic income pilots for people with disabilities that did not count against SSI, and careful documentation of the huge difference that would inevitably make, and then leveraging that sort of data to try to influence policy in the future. And I'll leave it with that.
I suppose if you combine your 3 wishes into one, that's what you get, right? Wonderful. Well, thank you so much to our wonderful panel for all of this today. It's been a lot of fun getting to be in conversation with you, as it always is, but thank you to everyone for all that you shared. Taylor Carty is the Eileen Sweeney Disability Policy Intern this summer with the National Academy of Social Insurance. Keith Jones is the president and CEO and a lot of other things at Soul Touch and Enterprises. Maria Town is president and CEO of the American Association of People with Disabilities, AAPD, and Nev Jones is an assistant professor at the University of Pittsburgh, whose research I'm really excited to be bringing more into the Academy network. Thanks to all of you. Thanks to everyone for joining us in cyberspace, and happy Disability Pride Month and happy ADA anniversary, everyone.
Take care. Bye-bye.
Thank you.